the final full-length presentation of the day, and we've saved the best for last. We're bringing Dr. Sajeev Thomas has come up from Orlando because he didn't know it was so cold here, and leaving right afterwards. But in between, he's going to talk about an immunotherapy trial for neuroendocrine cancer patients. So please welcome Dr. Thomas.
Yeah, good. My name is Sajeev Thomas, medical oncologist at the University of Florida. I'd like to thank Bob and Marianne for having me up here and speak to you guys. I wish I brought a little more warmth from Florida. It's definitely cold. On the way over here, I actually bought this sweater because it was that cold. I'm not as acclimated. I'll be talking about immunotherapy. I think immunotherapy has been a big hit, a big game changer in the world of oncology. In the world of neuro and endocrine tumors, it's still a little early to say what exactly it's going to do, but I think there's some interesting data coming out, at least some signs and signals that maybe immunotherapy might be a good option, or at least maybe one of the weapons we'll use in treating patients who have neuroendocrine tumor. Now, at my institution, I see primarily melanoma sarcoma and then 30–40% GI gastrointestinal tumors. And so you can imagine in the melanoma world, if you guys haven't heard of it, this has been a game changer. Everyone knows who this person is, right? This is President Carter. If you don't know what happened to him, he had melanoma that spread to his liver and to his brain. And he's a year out in complete remission, getting immunotherapy. Now, if he had this kind of cancer 5–6 years ago, this would have been a death sentence, to speak bluntly, right? If you got the metastatic melanoma, your median survival was 6 to 8 months, and with brain metastasis, it's probably around 2 months, right? And so here he is, a year out, working for Habitat for Humanity, very active, 92 years old, right? And so not only in remission, but getting drug that is also fairly well tolerated, probably arguably much better tolerated than any other drug we have to give, even for neuroendocrine tumors. And this is, I have 100 folks like this in my practice where they are year out, 2, 3, 4 years out without cancer coming back. And many times they're actually stopping the therapy and nothing's coming back. And so for the first time, it looks like we're curing these guys. I never have to get to say that word, C word, that cure word, but it looks like that. From a immunotherapy standpoint, historically speaking, it's not a new idea. It's actually been around for a while. One of the very first form of immunotherapy to treat a disease is vaccination against the infectious stuff, right? Smallpox, that's eradicated because of vaccination. Interestingly, this is Dr. Jenner, who noticed that the milkmaids, or I guess the ladies who handle cows, when the cows got cowpox, those ladies never went on to get smallpox. And so what did he do? He takes I guess some virus from a cowpox infection and injects it into an 8-year-old boy. You can't do that today, right? So it does that at that time, and that kid did not get smallpox. Right now, smallpox is completely eradicated. And so what are we doing with vaccination? When you're getting vaccinated, you are injecting dead parts of the virus, dead parts of that bacteria, so the immune system can pick up those dead parts and maybe recognize it so that when the real guy shows up, it's ready for it. And that's the whole point of vaccination. Maybe this could be something that's also useful for cancer. Coley's toxin, I don't know if anybody heard of this. I've never heard of it until we got into immunotherapy. But a surgeon who treats sarcoma back in the early 1900s, who saw or observed that when his patients were infected with bacterial infections, he saw some regression of the tumors, and these were patients who had unresectable tumors. And so what did he do? He said, well, let's put a bunch of live bacteria and inject it in patients. In a time, I'm sure antibiotics was probably not even around at that time, but knowing that that's not a good thing to give live bacteria, right? So let's kill it and then give it to patients, and then quote unquote seeing some observations or seeing some regression in the tumors. This later became known as Coley's toxin, and it was kind of given over the 1940s and 50s, but again, maybe a sign that if we can rev up the immune system, create some inflammation, maybe the immune cells can recognize the cancer and kill it. Now, this is a bit of a diagram over here. If you can just bear with me, I have a better picture on the next slide over here. If you look over here, you got cancer cells. There's cancer-specific antigens or proteins that can get picked up by the antigen-presenting cells. These are typically dendritic cells that can then present those antigens, those cancer-specific antigens, those unique proteins that makes it very unique to that cancer cell compared to all the other normal cells. That antigen-presenting cell then presents it to inactive T cells, these inactive T cells are now activated, proliferating, circulating into the environment, the circulatory system, and then getting into the tumor microenvironment. And if it has a receptor that actually can recognize that antigen, it can potentially kill it. And then you get a tumor response. And then you also have physiological breaks or checkpoint to kind of keep this in check. Otherwise, if you have a continuously turned on immune system, you can get serious autoimmune related issues. And so we'll talk about these checkpoint pathways. Now, I guess I'm from the MTV generation. I like to visualize this. I like graphics. And so this is a dendritic cell, an inactivated T cell, now activated, and then we got an ugly-looking cancer cell. You can't get more graphical than that, right? And the way you can think about this is kind of like that dendritic cells acting like your scout, and your T cells are your marines of the body that can recognize virus, recognize bacteria, recognize cancer cells, and if it can recognize it, it can go ahead and kill it. Now, the other part of the equation is that cancer cell has to be recognizable in the first place. It has to have something potentially different to be susceptible to immunotherapy. And so now again, I told you immunotherapy is not a new idea. It's been around for a while. Some of the ways we've done it was taking the tumor out of a patient, isolate the T cells in a dish, and then clone that T cell, right, by the billions, and give it back to the patient. Because those T cells are there in the tumor microenvironment, but they're not finishing off the job, right? But maybe if you can clone them by the billions and infuse it back to the patient, you get responses. In melanoma world, if you did that, about 20% of the time, you had a complete response that also looked like cure, a small number of patients. The other way to do this is create vaccines, right? Get the melanoma dead parts, the cancer-specific dead parts, and inject it back to the patient, or use the cytokines. These are sort of the crosstalk between the dendritic cell and the T cell. Maybe you can, clone that or infuse that by the billions or high amounts, and maybe rev up or create inflammation, and that can get some response. One of the newest ways is really the checkpoint inhibitors. I'm sure you guys are seeing the commercials for Opdivo, and you're probably seeing a lot or hearing a lot about immunotherapy. And a lot of it is just stemmed from these checkpoint inhibitors that are showing some amazing responses. I'll show you some scans on that. But one of the very first cytokine and form of immunotherapy we've been using for a melanoma patient was IL-2. Now, if I give this to 100 patients, and these are folks that were admitted to the hospital, stage 4 metastatic melanoma, you got a dose every 8 hours. You're supposed to get 14 doses, but nobody gets 14 doses, right? By the time you get your 7th, 8th dose, you land in the ICU, right? You're sick, and then it usually recovers. It's reversible after a day or two. But if I did that to 100 patients, only 5% had a complete response. So that's 1 in 20 chance that you can get a complete response that did look like cure, because these are folks who had skin and lung metastasis, liver metastasis. Here's another example of lung disappearing. And again, if you're that lucky 5%, that 1 in 20 guy that had a complete response, this is over years, you kept it for the long term, and it looked like cure. And back prior to 2011, that was your only option, IL-2 or chemotherapy, and chemotherapy for melanoma didn't really do much. Everyone with me so far? All right, well, now in 2011, we had our very first checkpoint inhibitor with Ipilimumab. And what this drug does, well, let me take a step back. You got cancer-specific antigens that are presented to the T cell. And once the T cell is activated, it proliferates and does what it does. But again, there's physiological breaks to suppress this. And so one of those physiological breaks is a CTLA-4 receptor. You with me? And then if I give an antibody called Ipilimumab that binds to those receptors, you are now releasing the brakes. You are now reactivating those T cells, and those T cells are revved up and proliferating. And hopefully it also has a receptor that can actually recognize the cancer and do what it does. And so again, releasing the brakes. Now, I'm a sci-fi guy. I like to think that you're creating a clone army of T cells potentially, okay? And then and now if I give this drug to 100 patients, it was like 20 to 25% had this long-term disease control. So to go from IL-2 1 in 20 to 1 in 5 is a big step. I still have folks who are 3 or 4 years out without their melanoma coming back, which is pretty impressive. Even after just 2 or 3 doses. They're not taking a drug every day. They're not taking a shot every 4 weeks or a pill every day, right? Just enough to get the immune system turned on, and if it can recognize the cancer, kill it. So 1 in 20 with IL-2, 1 in 5 with Ipilimumab. And then 3 years ago, we had this new drug called a PD-1 inhibitor. This is the drug you're probably hearing more about. And what is PD-1 is, it's basically like a biochemical shield. PD-L1, PD-L2 on the cancer cell surface, when it binds to the PD-1 on the T cell surface, it's kind of like the cancer cell telling the T cell, hey, I'm you, do not attack. Or in other words, a biochemical shield. That's how I think of it. So Independence Day, right? So you got that shield there. Or in other words, you can't tell the difference between the normal guy and the cancer cell guy. So what if you can give an antibody that kind of interferes with that interaction between PD-L1, PD-L2, and the PD-1? So PD-L1, PD-L2 on the cancer cell surface and PD-1 on the T cell surface. Can we get responses? Can we take down the shield? And when we did that to 100 patients, it was around 30 to 40% response. And that is now moving the bar up to 1 in 3. So IL-2, 1 in 20, Ipilimumab, 1 in 5, and PD-1, 1 in 3. Now, what if we just put both drugs together, right? Take a drug that's going to make your reactivate your T cells and have your T cells proliferating, create that clone army, and then take down the shields. And I think this is the best holistic approach to treating patients. These drugs are not acting on the cancer directly. You're treating the immune system, turning it on. And when you did this to 100 patients, it's basically every other patient I treat who get a response. And if you can get a response, by the time I do that next CAT scan, usually about 80, 90% of the time, it can be a long-term, durable response. And again, many of these folks are actually coming off therapy. So these are survival curves. I just told you IL-2, this is kind of like that curve. And if you start at the beginning, 90, 95% of patients died beyond 2 years. This is the 1 in 5 with Ipilimumab, 1 in 3 with PD-1, and now with both drugs together, it's basically every other patient I treat in the melanoma world. And this is really exciting. This is an example of a lady with lumpy, bumpy tumors. You can see it on the CAT scan. Now she has nothing but a melanin tattoo. Here's a 93-year-old lady that I treated, just took it for 2 months and we stopped it. She had other medical issues to deal with. But still, for a 93-year-old lady to take immunotherapy, very well tolerated, and all we have is a melanin tattoo. Here's the 83-year-old guy that one of my first patients on the study from 3 years ago, 10-centimeter mass in the liver, down to now it's about a centimeter in size. This is when we started in 2013, and we're maybe a year and a half into his therapy. He's asking me the question, well, how long do we keep going? Because he's coming in every 2 weeks to get this drug. He's actually from New York, too. He was flying in during the summer just to get the drug on the immunotherapy. So I made a deal with this guy. I said, well, I'll biopsy the spot. And if we biopsy it and there's no evidence of cancer, let's stop. And if there's any residual cancer, let's keep going. So do a biopsy, and it was completely inflammatory. Inflamed tissue, no evidence of cancer. What do you think he did? You think he stopped it, or you think he kept going? Kept going? Yeah, he kept going. He wasn't going to stop, right? So he kept going for another 6, 8 months and then decided to stop. He's probably more than a year out after stopping the drug, and still nothing has come back. Here's another guy with what I call cannonballs in the lungs. Again, complete response, and he's doing well. This is a 40-year-old guy with just huge bulk. This guy had a very slow-growing melanoma and literally watched his cancer grow over a 2-year period because he was doing alternative stuff. And obviously, it wasn't working for him, and so February, he had developed brain metastasis. That's when he was enlightened to do something about it. He had brain surgery, some radiation therapy, and then he started a PD-1. And to go from all this to practically nothing, it's pretty incredible. Now, maybe about 2 or 3 months ago, he had one isolated spot that grew, one oligometastatic spot. Despite well-controlled disease everywhere else, one new lesion in the left lung, and we applied some ablative radiotherapy to that spot. He continues to do well. For him, I'm not stopping it. He will continue on for a while. Here's another guy with a mass by the face, shrinking down to almost nothing. And you have a biopsy before and a biopsy after. This is what we see under the microscope. And you can see all these cells over here, there's big dark blue cells over here, purplish cells. Those are all melanoma cells. And over here you see a lot of T cells, sort of this Lord of the Ring battle between the immune system and the cancer cells. And then after therapy, nothing but inflammatory cells, no evidence of cancer on treatment. The other unique thing we see about immunotherapy is sometimes we see this pseudoprogressive process. If this was chemotherapy or targeted therapy or everolimus or octreotide, and you did a CAT scan, you saw lesions like this, you can take it to the bank. That is progression of cancer. But here's an example where you get immunotherapy and it looks like the cancer is getting worse or tumors are getting worse, but it's really an inflammatory reaction. And this is after 4 doses of that Ipilimumab, and you give a little time, all those lesions get better. This patient is doing well today, right, without cancer coming back. The other thing is sometimes we can see very quick response. We used to think that immunotherapy took time for it to work or to rev up, and maybe 6, 8, 10 weeks later you may start to see the responses. Here's an example of one patient getting 1 dose of Ipi and Nivo and basically left a hole. They didn't even get time for the body to heal itself while it's, while the tumor or the cancer is improving. And so now we may need to worry about symptoms from too good of a response, right? What if that was your brain or lung or the intestinal tract? This year at our conference, there's some data to say, well, now, well, first of all, no one knew these drugs were going to work so well, right? You continue the drug every 2-3 weeks until evidence of progression or toxicity or you wanted to stop. And here's an example or some data where folks who had a complete response to therapy and they stopped the drug, 97% kept it long term without seeing cancer come back. That's pretty impressive. So what are we doing over here when we give immunotherapy? Are we pushing the immune system back to a state of elimination, cure? Or are we pushing it to a point of where it's equilibrium or a state of where we're keeping the cancer in check, nothing's growing, no new tumors, but maybe over time some resistant clones may show up. And for example, that one patient that had that left lung lesion grow despite well-controlled disease elsewhere. And so I think for some patients we are curing, and for others, I think we may be just keeping it at bay. I have a patient who had, I think I started his therapy in 2013, and despite well-controlled lung disease, over a year and a half, he had a new brain spot popping up every 2 or 3 months. I counted 11 brain lesions over the year and a half. And every time he popped up with a new spot, we would just apply radiotherapy, stereotactic radiation therapy, and knock it out. His last brain spot was February 2015, and maybe in the last couple of months, we just stopped his therapy. So that's pretty impressive to see that. Well-controlled systemic disease, and occasionally we may see some new spots elsewhere, but maybe we can do something about that with other modalities, with our surgeons, with our radiation folks to treat those spots. Now, with immunotherapy, we can also see some very interesting side effects. You can get diarrhea. I know for carcinoid syndrome that diarrhea is one issue, but this would be a different kind of diarrhea. This is immune-related diarrhea and colitis. Most common symptoms we see is more rash, itchy skin, endocrinopathy, and then you can get some pretty uncommon, rare, but life-threatening effects too. But the good news, if you start some steroids, most times you can shut it down, and occasionally I may need to admit people to the hospital and do IV drugs, stronger medications to shut down the immune system. Because sometimes the immune system can be so overactive that that might be the problem and no longer the cancer. And so again, some interesting side effects that we can talk about later on if we need to. Now the other thing I think is interesting, I think it's a form of immunotherapy as well. It's the very first virus approved to treat cancer is TVEC, telemagene laharparapavec. That's the full name of it, right? TVEC. It's a modified herpes virus so that it selectively replicates within the cancer cells, not so much in the normal cells, but also modified in a way so that it can secrete or make GM-CSF, which stimulates some of the immune cells nearby. So you're making new virus, you're making GM-CSF that's going to stimulate the immune system, and you're creating dead parts, cancer dead parts, and maybe the immune cells can come by and pick up. And then maybe that can get you responses in other parts of the body that were not injected. Okay, so I got to inject this. I see a lesion, there's something palpable, I inject this virus, but then I can see spots in the lung and liver also disappearing with this kind of therapy. So it is a form of immunotherapy. Here's some examples of some local responses, and here's an example of lung lesions actually improving with this therapy. There's nothing specific for melanoma. This could be applied to Merkel cell, head and neck, sarcomas, pretty much any tumor that is palpable. And I think Amgen will probably move in that direction soon. But again, the point is creating cancer-specific antigens so the immune system can recognize it and hopefully get an immune response. This is the current state of immunotherapy. It's not just for melanoma. Now you have multiple new indications for lung, renal, head and neck, Hodgkin, bladder, I think soon to come upper GI, hepatoma, anal cancers. What about neuroendocrine tumor? I'm at a NET conference, right? So what does this have to do with you guys? Well, there are some signs and some signals that maybe immunotherapy can work for neuroendocrine tumor. One of the things we learned is microsatellite unstable malignancies are very sensitive to immunotherapy. I'll show you some data on that. And then there are some other markers we can look at with high mutational load and PD-L1 expression. You can look for that under the biopsy or on the path. And maybe that might be a sign that immunotherapy might be an option for patients. Call it cancer, whatever. As long as those things are there, maybe that might be an option. This is, if you asked me, 2 years ago if this was going to work for colon cancer, I would say we don't know. And then if you asked me in the past year or so, would it work for colon cancer, I would say no, it does not work for the majority of colon cancer patients. Here's an example. Out of 33 patients with metastatic colon cancer getting immunotherapy, 32 out of the 33, it didn't do a darn thing. But for that one patient out of the 33, it melted the cancer like butter. Right? Had a complete response. What was so special about that patient? Well, he had what we call microsatellite instability. And what is microsatellite instability? Well, it's a defect in the DNA repair protein. So there's about 4 of them, and if you're missing one of them, then that cancer cell or that cell does not have the ability to repair itself if it becomes mutated. And so if you're the way I would think about this, like if you have a building right here, I'm trying to come up with an analogy over here, right? You have a building and you have IT, you got security, you got housekeeping, you got maintenance, and if you're missing one of those, maybe you might be, you may not be able to keep up and maintain yourself. And so if you're missing a DNA repair protein, then you would be microsatellite unstable. And if you have them all intact, you would be microsatellite stable. And so if you're microsatellite instable, your average mutational load was around 1,700 mutations. And if you're microsatellite stable, it was only at 73. Now, what does that mean? Well, if you have a lot of mutations, maybe that's going to create a protein that's very unique to that cancer cell and not seen on the normal cells in the body, and maybe that might be potentially susceptible to immunotherapy. All right, so in the world of neuroendocrine tumors, I don't think MSI is going to be high. I don't know if there's any data on MSI. I doubt it's going to be high. I'm pretty sure it's going to be none or low. But we can look at somatic mutations and get some recognition or maybe some idea or sign or a signal that immunotherapy might work or may not work. But if you look at somatic mutations and these are all the cancers over here on the x-axis, and on the y-axis is the number of mutations seen. If you look all the way to the right, look at the cancers that have a very high mutational load. Melanoma, lung cancer, bladder, head and neck, and then soon you'll have upper GI pretty soon that'll be approved for immunotherapy. And then carcinoid is way back here on the left side with a very low rate of mutation, somatic mutations. We already know for our PD-1s that for immunotherapy for prostate and maybe most breast and pancreas cancers, it doesn't really work that well. And maybe that might be challenged in the future, but for now with the current drugs, it's not working very well. And if you look at this colon cancer over here, it's a full spectrum, and there's maybe this top portion over here with the very high mutational load, that high somatic mutations that may say or be a sign that these are the ones that work the best for immunotherapy. So if you're a colon cancer and your MSI high, this is that blue line. If you're some other cancer and your MSI high, that's that black line over here. This could have been uterine, small bowel, hepatobiliary, didn't matter. And if you were MSI high, you had a chance, the immunotherapy was going to work 70, 80% of the time. And if you're non-colon, it was around 67% of the time. And again, look at that. That's each line represents a patient. And over time, you see tumors shrinking and continuing to be maintained or stable. And look how durable that is in days. This would be a year out with stable disease. That's pretty impressive. All right, so carcinoid, again, low mutation load. Does that mean immunotherapy would not work for that kind of patient? Well, let's see if we can find another marker. This is data that was presented at NANET's conference this year, looking at PD-L1 and PD-L2 and TILs under the microscope. Can we see this kind of stuff? Remember I told you that PD-1 and PD-L1 are sort of signs that the cancer cells are suppressing the immune response. You with me with this? So signs that the cancer cell is protecting itself, has that shield, or signs that the immune cells are there in the tumor microenvironment. So if you looked at 64 patients who had small intestinal nets and 21 patients with pancreatic nets, PD-L1 expression was virtually pretty low or not existent. With PD-L2, though, they saw that 80, 90% were positive. And then with TILs, or tumor-infiltrating lymphocyte, they saw more of it in the pancreas and maybe a little less so in the small intestinal. So a sign that maybe immunotherapy might work for these kinds of patients. Pulmonary nets, 80 patients, 58% PD-L1 positive, and then PD-1, 51% of the time. So again, another sign, signal that immunotherapy might be an advantage to treating these kinds of patients. So right now there's various studies actually ongoing, or actually maybe even complete. We've participated in an eMERGE study where 50 to 100 patients with neuroendocrine tumor can be enrolled and get Pembrolizumab, one of the PD-1 inhibitors. We put about 5 patients on that study. I would say 2 progressed, 2 had stable disease. Here's my one responder. Okay, low grade pulmonary neuroendocrine tumor, Ki-67 of about 1%, and only had prior sandostatin, never had Infinitor, never had chemotherapy, and gets immunotherapy. You can see a significant shrinkage in the tumor on the left lung and also liver metastasis. Started in May, currently getting her 11th or 12th dose of PD-1. Pretty impressive. This is the first NET patient I've seen where immunotherapy actually worked. So we'll see. I think there's going to be more data coming up this coming year looking at what the PD-1 and what immunotherapy is going to do for low and intermediate grade NETs. We do have some data for the high grade NETs. And if you guys already heard from today that the high grade NETs, the small cell types, the ones where they have a Ki-67 of 70, 80, 90, 100%, really high grade, this would be small cell and Merkel cell, or high grade neuroendocrine tumors of the skin and lung. We already have some data on this. This is presented at ASCO this year, 216 patients randomized to either getting the PD-1 by itself or the combination of CTLA-4 and PD-1 at various doses. And if you look at the response with just one drug, it was around 10%. And if you look at the response for the combination, it was around 20%. But also look at the stable disease. It was also an additional 20%. And stable disease can also be very good too, because this can be very durable. This would be the combination of Nivolumab and Ipilimumab, where you get really good responses, and it's looking durable right there. And then you also have folks who are stable disease, and each line represents a patient over time. And you can see that the lines are not skyrocketing up. They're actually stable over time. So a disease control rate of maybe 30 to 40% in the high-grade NET population. This would be an example of a small cell responding to the immunotherapy with METs completely shrinking down. I think the main question right now is, I think these responses are there. It's just going to be a question whether it would stay this way. Are we going to see in this tumor type and in NETs overall what we're seeing in melanoma in terms of, it looks like the cancer's gone. It doesn't come back. Here's a patient I treated with small cell. I met her in January 2014. You can see that her liver was chocolate disease. She's had several rounds, 2.5 years, been treating her with chemotherapy. And then in June of this year, I was able to get her PD-1. And here's her scan 3 months later. Great response, right? So if it's melanoma world, I would say to the patient, you have an 80, 90% chance that you may keep this, right? So that's a good chance. But for her, unfortunately, this is her scan this past week. This thing just took off, right? So clinically looking great for the first 3 or 4 months, but just within a very short period of time, this thing just took off. So we'll see. I think more to be determined. This is Avelumab, another inhibitor or PD-L1 inhibitor in Merkel cell. So Merkel cell is the high-grade neuroendocrine tumor of the skin. And same thing, we're seeing this 40% response where the tumor shrinks down and it looks very, very durable long-term. So, and this could be pretty impressive responses, right? And so right now, I would say for small cell, disease control rate 30, 40%, Merkel 30 to as high as 50%, 56%, although this was a small number of patients. This is actually on the NCCN compendium. You can actually argue this now with the insurance because insurance companies actually look at this to either approve or deny whether the drug can be given. This past week, I have a colorectal neuroendocrine tumor, high grade, who's seen platinum, who's seen temozolomide therapy, was also BRAF mutated for the physicians in the room. And I gave her BRAF MEK, shrunk it down for about 6 months, and now it finally grew and given PD-1. Initially denied by the insurance, but when you tell them to go look at the NCCN, they actually approved it for the high-grade NET. So we'll see how he responds to that PD-1 inhibitor. So on Merkel cell as well for the NCCN. So these are the questions, right? Is immunotherapy going to have a good response? Is it going to be another weapon in our arsenal to treat patients in addition to everything else we do? And if there is response, what is that response in respect to the grade? You know, between low, intermediate, and high grade? Is there any differences in responses between the primary sites, lung, pancreas, and GI, intestinal? And will it be durable? Are we going to see similar responses like we're seeing in the melanoma world? And how do we sequence with all the other options? From a toxicity standpoint, if you're just giving the one drug by itself, it's very well tolerated. 80% of the time, virtually no symptoms. And in 20% of the time, you can have mild, moderate symptoms. But when you put the two drugs together, very toxic. Okay, so 60 to 70% grade 3 toxicity. And you can see some pretty impressive toxicity issues with two drugs, but one drug by itself, fairly well tolerated. How do we sequence this? Can we combine it with immune chemotherapy? I have a Merkel cell right now where I'm doing both because he's got a liver full of disease, and there's some safety data in the lung cancer that you can do both together and not really cause more side effect issues. So again, we'll see if this is going to work. I think the other question is predictive markers, but you can apply that question to a variety of other things we do. Right now, as a net patient, you have options. Now, for a clinical trial standpoint, these things open up and close very quickly. I think for the net cohort that we had, it closed within a couple months. But checking with your center to see if you have an opportunity to get on a clinical trial to get the PD-1 therapy or immunotherapy. If you can't get on a study, well, now you can argue this a little bit with insurance companies to actually try this, at least for the high-grade folks, and maybe even for microsatellite unstable. And I didn't get into mutational load, but that's also something that we can argue with. And then the other opportunity, and for the first time, we were just talking about pharma company, how maybe we're a little bit cynical on them for what they do, but they actually, between BMS and Merck, they have these patient access programs where you can actually get free drug. They have not said no. I think we've had some experience that, you know, folks, if you request PD-1 from the pharma company, they can give it to you as long as you get it now from the insurance. Now, some folks would be a little bit of a naysayer and say, well, we're kind of experimenting, right? If I don't have data to support this, why am I trying something on a patient without full data? Well, just because you don't have data doesn't mean there's a lack of efficacy. And we have some very interesting responses in all other cancer types. Here's a cutaneous squamous cell that I treated last year. He is a year out. He had metastatic cancer. There is no data for PD-1 in this cancer type, right? And now there's 2 studies that are ongoing in this past year that started. They haven't even completed it yet. And if we weren't able to get this drug for him, he would not be alive today. He had metastatic to his chest, mediastinum. Here's a 40-year-old guy who also had cutaneous squamous cell to his arm. He lost his arm due to the tumor. He had multiple chemotherapies and targeted therapies in the past. You can see the tumors over there. You can see it's kind of eating through his chest and multiple lung mets. This guy was in a wheelchair. He was breathing 4 liters of oxygen. And so Bailey able to, you know, survive. He was declining very quickly. And I even told him hospice, you know, but they were pretty persistent. And I told them that we can try this PD-1 and this would be a Hail Mary. And it was a very good Hail Mary, right? Here we are a year later, everything's gone. Incomplete remission. He's up, walking. He's off all oxygen. You can't even tell he's sick, except the fact that he's missing an arm. He's got a tumor spot over here by the heart that also shrunk nicely. And just recently, just for interest for the physicians in the room, on a repeat scan, he had this 9 by 2 centimeter clot that was just seen incidentally on a CAT scan. This is an MRI. We had it removed. He saw the cardiothoracic surgeons. They removed it. 99% of it clot, and within it was residual squamous cell carcinoma. Did a PET scan. PET scan's completely negative. He is still on PD-1 as we speak. Here's a pleomorphic sarcoma. We had no data last year that, you know, the PD-1s would work for sarcoma. You can see this, you know, basically football size of a mass really shrunk down. And finally, some data this year that maybe the pleomorphic subtypes do respond a little bit better with the PD-1 and not so much the other types of sarcoma. Hepatoma. Here it is. Chemotherapy or TACE and radioembolization and Nexavar, AFP to 125,000. With 1 and 2 doses, it literally dropped down to double digit. So quick biochemical responses and later on radiographic response. And here's a cholangiocarcinoma that I've known for the last 3 or 4 years. Multiple lines of chemo, surgery, radiation, and just maybe 3 months of PD-1. You can see the tumor really shrinking down for her as well. So again, always going to recommend a clinical trial if you can get to it. I'm very optimistic that it's going to be an option for net patients. If you can't get to a center and you've already exhausted all other options, all proven options for what you have in the net world, then maybe an off-label approach either through insurance or through the patient access programs. All right, that's all I got.